doctors. This is Dr. Hira Salman. So, welcome to MCQ of the day from AMBOSS. And today we are going to solve one question from pulmonology. So, there you can see it's a study guideline from AMBOSS. So, once you click here on this asthma, it will redirect you to a page. So, once you have gone through the theory, you can just click here on this question bank. When you just click here on this question bank, you will receive something like this. So let's see, here we have 23 questions. So once you click on the start option, so there you go. We have a first question in front of us. So let's solve this question. A 2-year-old girl is brought to the emergency department in the middle of the night because of difficulties breathing. Her parents say that the breathing noises have become progressively worse throughout the day and are mainly heard when she inhales. They say that a change in posture does not seem to have any effect on her breathing. For the last 3 days, she has also had a runny nose and a harsh cough. She has not had hemoptysis. The parents are worried she may have accidentally swallowed something while playing with the toys, since she tends to put small things in her mouth. Her immunizations are up to date. She appears lethargic, and high-pitched wheezing is heard at rest during inhalation. Her skin tone is normal, her temperature is high, pulse is high, respirations are high, and blood pressure is okay. Pulse oximetry on room air shows an oxygen saturation of 97%, which is okay. Examination shows supraclavicular and intercostal retractions. So this is an important point here. Supraclavicular and intercostal retractions. There is diminished air movement bilaterally, and an X-ray of the neck and upper chest is shown. We'll see the X-ray. Which of the following is the most appropriate next step in management? So what we are going to do next for the management option. So she's a young girl. She's 2 years of age, and she brought in emergency department in the middle of the night. Important point here, middle of the night, emergency department, young girl, and she is having what? Difficulty in breathing. And that does not seem to have any effect on her breathing related to the posture. Change in posture does not seem to have any effect on her breathing. And she has a harsh cough. There you can see wheezing, high-pitched wheezing, fever, tachycardia, supraclavicular intercostal retractions. These are all important points here. And now look at this chest X-ray. We can see, great. So there is a classic sign which presents here, the classic steeple sign, pathognomic for Croup. So we have a diagnosis of Croup based on this X-ray and based on all these clinical findings. So now the question is asking which of the following is the most appropriate next step in management. The next step, are you going to give non-invasive ventilation to this patient, or oseltamivir or nebulized epinephrine, albuterol, and abiraterone inhaler, intravenous clindamycin, nebulized glucocorticoid, reassurance, or intubation? So based on the diagnosis which we have just made, the Croup, what we are going to do next. So let's just see the answers, and we are going to rule out one by one. Okay, so first we can see the highlighted points. 2-year-old, middle of the night, harsh cough, wheezing during inhalation, high-pitched wheezing, retractions. These are all important points. Now, a child with inspiratory stridor at rest, chest wall retractions, and diminished air movement most likely indicate Croup. And this patient's radiography demonstrates the classic steeple sign, indicating tracheal narrowing due to infection. So it's a classical case of Croup based on X-ray, based on the clinical findings. Now, what we're going to do next, are we going to give non-invasive ventilation? So non-invasive ventilation with humidified air oxygen can be used as an adjuvant treatment for Croup, but a more effective therapy is indicated at this time. So it's okay. Non-invasive ventilation is a part of treatment. It's adjuvant treatment, but right now they are asking what? They're asking the most appropriate next step. So we will not consider this. Now, oseltamivir is indicated for influenza in patients at increased risk for complication, for example, extremes of ages or immunocompromised people. While influenza can present with acute respiratory symptoms, for example, cough and fever, it is not a common cause of stridor. It's okay, the patients are in cough and fever, but stridor may not be because of influenza. Moreover, influenza can cause a variety of chest X-ray findings from normal to diffuse infiltrates, but it is unlikely to produce the results seen in this patient, like this steeple sign. We cannot find this steeple sign in case of influenza infection. We have some additional information here as well. The influenza virus can very rarely cause severe croup, in which case oseltamivir therapy would be given. In such cases of severe infection, severe croup, we can use this oseltamivir. Okay, so what about nebulized epinephrine? Nebulized epinephrine is the immediate treatment of choice for moderate to severe croup. Croup is considered moderate to severe if the patient has dyspnea and tachycardia at rest. Like in this case, the patient is having moderate to severe infection. Severe stridor with significant retraction and agitation, all of which are present in this child. So careful monitoring of the heart rate is important because epinephrine can worsen tachycardia. She's already having tachycardia, so we need to take care of this thing. In addition to epinephrine, oral parenteral glucocorticoids, usually dexamethasone, are indicated after administration. So in addition to epinephrine, but first you have to give epinephrine. So after administration of these agents, patients should continue to be monitored for improvement for next 3 to 4 hours. If symptoms improve, patients can be discharged home. Otherwise, patients should be admitted for airway monitoring and further treatment. So here the best option, which is considered the next step in management, is to nebulize this patient with epinephrine. We have some additional information here as well. An important differential diagnosis of croup is epiglottitis. So croup is a surgical emergency, while epiglottitis is a surgical emergency, while croup is a medical emergency. So it's one of the important differential diagnoses of croup, that is epiglottitis. So patients usually present with sudden onset of dyspnea, same presentation, dyspnea, labored breathing, but drooling, a muffled voice, and often assume a tripod position. Remember here in this case, it was clearly mentioned that they say that a change in posture does not seem to have any effect on her breathing. So this does not particularly indicate this case, right? Here we can see in case of epiglottitis, we have this tripod position, that is leaning forward and supporting the upper body with the hands. These patients require emergent airway management. So this is surgical emergency and intubation, as they can rapidly progress to respiratory failure. This disease has become rare in the US since immunization against Haemophilus influenza type B became mandatory. So because of the vaccination, we have less chances of this. Once you click here on this group, it will redirect you to the library, and then you can just have a look on the theory part of group. Now, why we haven't given this albuterol and ipratropium inhaler? Because albuterol and ipratropium are used in asthma exacerbations and COPD. COPD affects adult and the elderly with a history of smoking and sometimes alpha-1 antitrypsin deficiency, and would not affect a young child. Although asthma is a common pediatric disease and most of 80% of children affected develop symptoms before 5 years of age, for example, cough, wheezing. But while the characteristic wheeze of asthma can be mistaken for stridor, as in this patient we can be mistaken for stridor, but chest X-ray would be normal or show hyperinflation due to airway obstruction rather than this typical steeple sign. So the steeple sign is highly suggestive of croup. So if you can just have a look on this X-ray, so you can see here the hyperinflated lungs. So this is a typical finding in asthma we can find. But here, if you can just have a look again, so this X-ray, we have a typical croup steeple sign. So this steeple sign is pathognomic for croup. Okay, now albuterol is done. Now intravenous clindamycin. So clindamycin in combination with ceftriaxone and cefotaxime is a treatment for epiglottitis, which is an important differential diagnosis. We have already read this. Epiglottitis typically presents with acute, again high fever, so throat is there, muffled voice, stridor, drooling, sometime in children 6 to 12 years of age with a tripod position. But there's a very classic sign on lateral neck X-ray, which is diagnostic for epiglottitis, and that sign is thumbprint sign. So in croup, we have this steeple sign, while in this epiglottitis, we have thumbprint sign. So if you can just have a look here at this X-ray, you can see it's a thumbprint impression here. If you want me to make it more for you, so maybe a little less. See, it's a thumb impression here, thumbprint. So this is classic for epiglottitis. So moreover, her X-ray shows a different characteristic finding. That's a steeple sign, considering that the patient vaccinations are up to date. Remember the point here, was vaccination. Her immunizations are up to date, so she must have vaccinated for hemophilus influenza B as well. There is less chances of epiglottitis here in this case. Every point of the question is important and it gives you a clue. Please repeat the question again and again. So moreover, her X-ray shows this we are done. Up to date, there should be immunity against this one, hemophilus influenza type B, the primary cause of epiglottitis prior to introduction of the vaccine. Now, why we haven't this nebulized glucocorticoid? Of course, these glucocorticoids are used in the maintenance and prophylactic treatment of asthma. Asthma is a common pediatric disease, and more than 80% of children affected develop symptoms before 5 years of age. That's a repeated thing. While the characteristic wheeze of asthma can be mistaken for a stridor, as in this patient, a chest X-ray would be normal or show hyperinflation due to airway obstruction rather than the characteristic fetal sign. Remember, we are not going to give glucocorticoids in this case. Now, reassurance in patient with mild croup, mild stridor, no respiratory difficulty. If there is no respiratory difficulty, there's a mild stridor. But remember here in this case, the patient is not having mild stridor. The patient is having moderate to severe stridor. So reassurance can be sufficient as it decreases anxiety and therefore eases respiration. In addition to reassurance, parents should be advised that breathing cold air or cool mist, for example, sitting next to an open window or open refrigerator, can help to alleviate symptoms. Although these measures could provide a certain degree of relief in this patient, she presents with dyspnea as well as supraclavicular intercostal retractions and this require more intensive acute treatment. So reassurance will not help. And intubation is mainly for epiglottitis. That's surgical emergency. Croup is a medical emergency. We'll give epinephrine. So intubation is indicated when airway compromise is imminent. Although this patient is in respiratory distress, she is not hypoxemic or bradycardic, meaning that the risk of airway compromise is low. And if we just have a look on this additional information, severe croup requiring intubation is rare. It may require, but it's very rare and occurs in less than 1% of infants. However, patients with signs of severe croup should always be hospitalized and monitored, especially for 4 hours, and then we will decide accordingly. So this is all about this question. So what is the main education objective of this question is to have a look on the management part of croup, because the patient who is having this difficulty in breathing, who is having harsh cough, who is having wheezing during inhalation, high-pitched wheezing and retraction, especially intercostal retraction with the classical steeple sign on X-ray is suggestive of croup. And what you're going to do, the best next step in management will be nebulized epinephrine. So this is all about this. See you next session. Bye-bye.